Hello, my name is Dr. Henry Silverman, and today I would like to discuss the topic of boundary issues in the practice of medicine. I would like to begin by saying a few words about the doctor-patient relationship. This relationship is described as a fiduciary relationship whereby a person in a position of vulnerability entrusts his or her welfare to another person. As such, patients' interests need to be primary, and physicians must place the interests of patients ahead of their own. Accordingly, professionals must monitor their self-interest. With that description, let's begin to discuss the concept of a boundary and why boundaries are necessary in the doctor-patient relationship. According to the dictionary, a boundary represents a line that marks the limits of an area, a so-called dividing line. In regards to the physician-patient relationship, a boundary represents a physical or psychological barrier that divides, separates, or defines the limits of interaction. This slide shows a pictorial description of boundaries, which emphasizes that a boundary represents the separation of the respective personal spaces of the physician and the patient. As a rule, a professional distance must be maintained between the personal spheres of the physician and the patient. Now, a boundary crossing represents departures from usual professional medical practices. As I will discuss, at times, crossing this boundary might actually be helpful for patient care. However, in most cases, when these boundaries cross, the potential for harms to the patient becomes a distinct possibility. Another definition of professional boundaries is shown in this slide. Professional boundaries may be defined as the expected and accepted psychological, social, physical distances between a professional and his or her patient. Yet another definition is shown in this slide. Professional boundaries are the dividing lines which separate the therapeutic behavior of a professional caregiver from any behavior which, well-intentioned or not, could reduce the benefit of care or treatment to patients, clients, families, and communities. Such behaviors are deemed to be unprofessional. What is the purpose of boundaries in the doctor-patient relationship? The inequality in power in the doctor-patient relationship creates the need for protection. Boundaries define formally and informally how professionals are to exercise their power within the doctor-patient relationship. The concern is that there are many situations that have the potential for physicians to exploit the dependency of the patient for their self-interest rather than the interests of the patient. There are two major harms that can occur from boundary violations. First, boundary violations represent exploitation. Intimacy and the resulting power differential sets up potential for exploitation of the patient. Essentially, one exploits the dependent relationship that satisfies one's self-interest instead of the patient's best interest. Alternatively, when physicians have what we call dual relationships with their patients, that is, a relationship other than a therapeutic relationship, for example, friendship, business relationship, one may lose objectivity in decision-making, which can endanger patient welfare. Examples include prescribing drugs for family members or accepting gifts from patients. Both types of boundary violations represent potential harm to the patient. As mentioned before, there is a difference between a boundary crossing and a boundary violation. A crossing represents departures from usual practices that might be beneficial to the patient. A violation indicates that a crossing has caused harm to the patient. The line between crossings and violations is imprecise, and any boundary crossing may cause harm to patients or to the therapeutic relationship. One may consider professional behavior to exist on a continuum, and the question is, where do we draw the line between professional and unprofessional behavior? To the left of the continuum is a cold and distant relationship. To the right is an over-involved relationship leading to boundary violations. Healthcare providers should strive for the middle zone. The right distance, however, may not always be obvious. The types of boundary crossings are shown in this slide, and these include dual relationships, self-disclosure, exchange of gifts, improper language, and then we have sexual impropriety, sexual transgressions, and sexual contact. Dual relationships or multiple relationships refers to any situation where multiple roles exist between a physician and a patient. That is, another role in addition to the therapeutic role. Examples of dual relationships include when the patient is also a student, a friend, a family member, an employee, or a professional business associate of the physician. Although dual relationships are not necessarily exploitative, there are several potential concerns if the physician tries to maintain both roles with the patient. First, due to emotional involvement, physicians may not be able to focus exclusively on the patient's well-being and lose objective decision-making. An example is the inability to deal with non-compliance issues with the patient when the patient is a family member or friend. Second, dual relationships may contaminate the doctor-patient relationship. For example, financial relationships or business transactions may lead to resentment or dependency that interferes with the physician's ability to empathize, be sensitive, and selfless in the physician-patient relationship. Regarding gifts, small non-monetary gifts such as baked cookies or a knitted sweater may represent benign boundary crossings in which patients wish to show their gratitude. However, more significant and expensive gifts may be problematic. For example, gift giving may be a conscious or unconscious bribe designed to obtain special favors from the physicians, such as shorter wait times for appointment times. Also, physicians who receive expensive gifts may feel an obligation that influences their clinical judgment in much the same way gifts from drug companies. Regarding the issue of self-disclosure, while physicians commonly chat with their patients about matters of mutual interest in an effort to build rapport and put the patient at ease, excessive self-disclosure may create difficulties for the patient and strain the relationship. Self-disclosure represents a role reversal in which physician starts disclosing personal problems to the patient. Even if revealing personal issues to a patient does not lead progressively to more extreme boundary violations, self-disclosure is itself a boundary problem because it is a misuse of the patient's time to satisfy one's own needs for comfort or sympathy. It is also inappropriate to try to extract care from oneself when a patient is paying their physician's time. Moreover, the patient may find sharing health concerns extremely difficult if the physician is perceived as needy and vulnerable. The remainder of this presentation will be devoted to sexual boundary violations. A definition of sexual misconduct is as follows: the overt or covert expression of romantic or erotic thoughts, feelings, or gestures by a professional towards a patient or staff that are sexual or may be reasonably construed or interpreted as sexual demeaning or demonstrate a lack of respect for the person's privacy. Sexual boundary violations occur wherever a clinical or therapeutic relationship is turned into a sexual or sexualized encounter that serves the self-interest of the physician. Clinical interventions necessarily involve crossing ordinary social boundaries in order to do physical examinations or to explore difficult feelings and emotions. This can only be done if the patient can be sure that this is a safe and non-sexual space that he or she shares with the physician. There are three types of sexual misconduct. These include sexual impropriety, sexual transgressions, and sexual violations. Let's define these terms. Sexual impropriety consists of behaviors, gestures, or expressions that are seductive, sexually suggestive, or sexually demeaning to a patient, including but not limited to disrobing or draping practices that reflect a lack of respect for the patient's privacy, sexualized comments or sexual demeaning remarks about the patient's body or underclothing, criticizing the patient's sexual orientation, potential sexual performance, sexual likes, dislikes when not clinically indicated. Also, sexual harassment remarks and soliciting a date. Sexual transgressions represent inappropriate and sexualized touching of a patient that stops short of overt sexual relations. Examples include erotic kissing, inappropriate hugging, and touching of the breast or genital area when not appropriate for the physical examination. This slide shows a recent newspaper story involving an emergency room doctor who was charged with sexually abusing 4 women who were under his care. Sexual violation represents physician-patient sex, whether or not initiated by the patient. The incidence of sexual misconduct is shown in this slide, which highlights the results of several studies asking physicians to complete a confidential questionnaire. Doctors who were surveyed represented several types of specialties that are known to be at high risk for sexual misconduct, and these include GYN, psychiatry, internal medicine, and family practice. The last column reports the percentage of physicians who self-reported having engaged in sexual misconduct. The range of reported sexual contact is between 3 and 12%, which represents a very high number. Red flag situations that denote a concern for impending sexual misconduct are shown in this slide. Doctors who start talking to patients about their personal life, doctors who check their personal appearance before a particular patient arrives, a patient is scheduled at the end of the day to allow more time for conversation, and a doctor who allows staff to leave early while he or she interacts with a particular patient. There are also risk factors that increase the likelihood that sexual misconduct may occur. For example, the setting of the practice serves as a risk factor if the setting is one of enforced privacy, for example, a solo practice. Another risk factor involves the types of patients being seen. For example, practices in which doctors obtain private, sensitive information may lead to over-involved emotional relationships, and this occurs predominantly with patients seen in the practices of psychiatry, OB/GYN, and primary care. Also, if patients have specific vulnerabilities, for example, a prior history of sexual abuse, substance abuse, or psychiatric illness, the likelihood of sexual misconduct may be higher. Another risk factor involves the type of therapy or services offered. For example, the risk is higher with long-term psychotherapy as opposed to short-term psychotherapy. Again, all of these risk factors increase the likelihood of inappropriate behavior. Other risk factors involve the vulnerabilities of the healthcare provider. These include situational stresses such as marital and family problems, burnout, and a heavy workload. Other vulnerabilities include experiencing psychiatric illness or mood disorder. Also, a sense of grandiosity, entitlement, and infallibility may also lead to an increased likelihood of sexual misconduct. Finally, lack of education and training serves as a risk factor for Sexual misconduct has several effects on the victim. The initial response is one of shock, shame, and denial. And then there are enduring harms on the victims, and these include post-traumatic stress disorder, psychological symptoms, mistrust in the profession of medicine, a sense of betrayal and exploitation, and a sense of guilt and self-blame. There are also harmful effects on the professional. First, there is an initial reaction of shock and denial. Then there is shame once there is realization of the impact of their seemingly innocent behavior on patients. Finally, there is the terror of the unknown regarding reactions from family and friends and loss of reputation professionally. Let me end by mentioning several general truths about prevention of boundary violations. First, be aware of red flag situations, and also develop a boundary plan that addresses certain risk factors that we discuss. Also, acknowledge personal vulnerabilities and seek help. Also realize that no level of training confers protection from sexual misconduct by a professional. Essentially, the power always rests with the doctor and the realization that the patient is vulnerable even if the patient initiates the unethical act. Thank you very much.